These videos have been developed for instructional purposes. For this reason, the nursing students and nursing instructor review the steps of the skills at the bedside. In actual nursing practice, you and your instructor should decide if this approach is appropriate for you.
So, Robert, what did you do this weekend?
Well, I went snowboarding.
Really? You know, I went to the John Chavis Band concert. Have you heard of them?
No.
Oh, well, what kind of music do you listen to?
Oh, I just listen to some classical music. They say it opens up brain power or something, so I listen to it when I study.
Really? Who told you that?
Oh, the music?
Yeah.
I heard it from a motivational speaper.
Motivational speaker?
That's right.
Good morning, everyone.
Good morning.
I always walk into the most interesting conversations in this room. Well, today, if we can gather around for a minute, I'd like to focus on nutrition. What is the preferred method of receiving nutrition?
Oral feeding.
Exactly. Now, when the oral route is compromised or not appropriate, what is the next best method?
Enteral.
Which means what?
Nutrients are passed through a tube into the gastrointestinal tract to give nutrients to the patient.
Right. Now, we'll look at nasogastric tubes, or an NG tube, which enters the nose and is passed into the stomach. We'll also look at gastrostomy tubes, which enter the stomach through the abdominal wall.
Miss Swenson, what risks are associated with the NG tube?
Well, the biggest risk is the tube feeding formula being aspirated into the lungs.
What else can an NG tube be used for?
Well, they can be used to decompress or drain fluid or air from the stomach. Now, I'd like to observe each of you as you provide care for your patients so I can be there if you have any questions or concerns, okay?
Okay.
Sounds good.
All right. Well, I'm going to be following Jeannie to her first patient, so I'll catch up with the two of you in a little while, all right?
Okay.
See you later.
Thank you.
All right.
Good luck.
Bye-bye.
See?
Classical music.
Yeah. Beethoven, if you're really into the heavy stuff.
Miss Swenson, my first patient's been prescribed an NG tube to relieve her nausea and vomiting while we treat her paralytic ileus.
Does the patient know the reason for the tube?
Yeah, her doctor explained it to her, and she's agreed to have it.
Well, why don't you gather your supplies, and I'll meet you there, okay? You'll do just fine.
Thanks. Hi, Mrs. Potter.
Hi.
This is Miss Swenson, my instructor. She's going to be working with me this morning. Is that all right?
Yeah, that's fine.
Okay. Now, I know the doctor talked to you about the tube for your stomach.
Mm-hmm.
I'd like to put it in.
Okay.
Once it's in place, you won't feel so nauseous, and you won't vomit.
Are you sure it's not going to hurt?
It might be a little bit uncomfortable going in, but I understand that it's not painful. Your throat might feel a little bit sore afterwards, but we can get the doctor to order some spray to help with that.
Okay, let's do it.
Okay, I'm just going to check your ID band. Can you tell me your full name, please?
Catherine Potter.
Okay. Now I'm going to need to assess your abdomen. I'll lie you flat and lift your gown. Is that okay?
Mm-hmm.
Okay. Now I'm just going to sit you all the way up.
Okay. Jeannie, be sure to have an emesis basin and tissues within reach during the procedure, okay?
Okay. Okay, what I'm going to need you to do is close one nostril and then the other. Tell me which one it's easier to breathe out of.
This one?
Okay, that'll be the one that we're going to use.
Okay.
I'm going to cover you with this waterproof pad. You can keep that basin handy right there.
Okay.
Okay, I'm going to measure to see how much tubing we need. Go from the nose to the earlobe, and then down to the
xiphoid process.
Thank you. Okay, I'll mark that with a piece of tape. Okay. I'm going to open this up. I'm going to put my gloves on. Now I'll just lubricate the tip of the tube about 1 to 2 inches with water-soluble lubricant.
Good, Jeannie.
Okay. Just lift your head. Here we go. Okay. Just put your chin to your chest and swallow the water. It'll help pass it down. Oh.
Very good. Now keep advancing the tube. Be sure to pause when the patient breathes. And don't force the tube, okay, Jeannie?
Okay. Okay, we're at the tape marking. Now I'll just check. You can relax. I'll just check to make sure that it's in the stomach.
I'll hold that.
Thank you. I'm going to aspirate a small amount of stomach contents.
What are you looking for, Jeannie?
Well, I'm assessing color and consistency. Gastric fluid can be green with particles, brown if old blood is present, or clear to straw-colored. This looks normal.
What other ways can you check if the tube is in the stomach, Jeannie? There are 2 other ways to check. You can measure the pH of aspirated fluid using the pH paper or a meter. Now, stomach contents have a range of 0 to 4. The other way is to obtain a radiograph or X-ray to confirm placement. A physician's order is required to obtain this film.
Okay, I'm going to take this tape off here. Not hurting you, am I?
Oh, it's okay. Okay.
Thank you, Miss Swenson.
Sure.
Now, this is going to be a little bit cold. I'm just going to apply something to your nose to protect it from the tape. All right, I'll let that dry.
Okay. Oh, good. Be sure not to pull the tube too tightly against the nose, Jeannie.
There we go. Thank you.
Okay. Now you'll want to measure the tube from the tip of the nose to the end of the tube. This measurement will help determine proper placement later, Jeannie.
Okay, looks like 24 inches. Now I'll just secure the tube to the gown using a rubber band and safety pin. I'll be sure to put the air vent above the level of the stomach. Okay.
Okay, let's attach her to the suction, Jeannie.
All right, Mrs. Potter, you did great.
What a relief. Wasn't so bad. It was uncomfortable and unpleasant, but just for a short time.
Well, I'm glad to hear it wasn't too bad. I'm going to help Mrs. Potter with oral hygiene now.
Okay. Very nice job, Jeannie. Now, when you document the procedure, you have to include a couple of things. The type and size of tube used, the nair used for insertion, the measurement of the exposed tube, the characteristics of the drainage in the tube, and the patient's response to the procedure.
No problem.
Okay? Thank you, Mrs. Potter.
Thank you.
Is it okay if I brush, or would you rather do it yourself?
I can do it.
Okay.
You know, the John Chavis Band is doing a free concert in the park in like 2 weeks.
Wow.
You're welcome to come if you want.
Is this a date?
Oh, don't flatter yourself. Come on.
Hi, guys.
Hi.
How's everybody doing?
Good, good.
Are you off to take care of your patient?
I am.
Okay, I'll catch up with you in a little bit.
See you later.
How are you doing with your patient's care, Robert?
Well, I've got a patient with an NG tube for continuous tube feedings. Now, he's starting the feedings because he's weak, debilitated, and cannot consume enough food to meet his needs.
Okay, well, let's check the chart for the type of feeding ordered, volume and frequency. Then you should gather supplies, check the expiration date on the formula, and head over to the patient's room, okay?
Sounds good.
Thank you.
Hi, Mr. Leverick.
Hello there. How are you?
How's it going?
Okay, Robert.
This is my instructor, Miss Swenson.
Hello.
Hi.
She'll be observing for a little bit as I give you your nutrition through your feeding tube. Okay?
Sure thing. But, tell me, what's it like outside? Is it cold?
It's pretty cold. Let me take a look at your ID band, okay? Can you tell me your name?
Rich Leverick.
Great, thank you. Let's move you up a little bit, okay?
Listen, I can't wait for the warm summer day. Grandkids by the pool.
Oh, I like the cold myself.
You know, they say that the people that like the cold like people.
Oh, yeah? Well, maybe that's right.
Well,
I like people.
I think it's because you stay inside so much of the time, you know. And it's obvious that you like people, too.
Oh, thanks. All right. Let me put this pad on you here. Thank you, Miss Swenson. Here we go. How's that?
It's fine.
Comfortable? Okay, let's get started.
You're using a pre-filled tube feeding setup. So you can start by removing the administration tubing from the package. Close the roller clamp and the slide clamp on the tubing.
Okay. There's the roller clamp. And here is the slide clamp.
Now you can hang the empty water bag.
Let me remove the tabs.
Remove the seal on the formula. Then remove the cap on the spike on the administration tubing set.
Okay.
Then push and twist the spike through the top of the formula bottle.
There we go. Now I'll just hang the bottle on the IV pole. And squeeze the drip chamber until it's about 1/3 to 1/2 capacity.
Okay.
There we go.
Now you can pour sterile water into the water bag up to the 750 milliliter mark, Robert.
Okay.
Be sure to lip it.
Okay. All right. 750 cc's, right? There we
Now
go.
close the top and rehang.
Now, what's the purpose of the water bag?
Well, this particular pump will automatically provide a 25 cc flush every hour, which eliminates the need to do it by hand.
That's pretty cool.
Great. Okay, now insert the cassette on the tubing
Okay.
into the pump. And close the lever on the machine.
Okay. Now I'll just open both clamps.
So the machine will prime the tubing for you, all right? Just turn the knob clockwise to the first notch, which
Okay.
is set rate, and it'll take a minute or two to prime.
The machine is flashing set rate.
So go ahead and set the rate using the arrow keys.
Okay. I'll set it for 30 cc's an hour.
Okay, Robert, now it's time to get your supplies ready
Okay.
because you're going to aspirate the gastric contents with the syringe to check for placement of the tube.
put some water into the container. Okay. Okay, now I'll just unclamp the tube.
Then return the contents immediately through the tube. Then we'll flush the tube with 30 milliliters of sterile water, Robert.
Okay.
Things look good, so continue with the feeding.
Now I'll just clamp the tube, disconnect the syringe, attach the feeding setup into the tube. Okay, and set the machine on run.
Well done. And as always, document the amount and type of feeding as well as the patient's response to the procedure. You can also document the volume on the intake and output record if indicated. Oh, and always ensure that the head of the bed is elevated at least 30 degrees. Okay, Robert?
All right, sounds good. How you feeling, Mr. Laverick?
Fine. Thank you, Robert. I appreciate it.
Nice job, Robert.
Thank you very much.
Thank you, Mr. Laverick.
Thank you.
You know what? I think I'm just going to stay and monitor to see how he tolerates the feeding, okay?
All right. Thank you.
Miss Swenson, can I borrow you for a moment?
Are you going to give me back?
Yes.
Then of course you can. What's up?
Well, my patient's receiving intermittent feedings using an enteral feeding pump, and his pump's broken. There's no other pump available from the processing center.
Well, then we'll switch to a gravity system in order to deliver the nutrition, okay?
That's great, thanks.
That's why I'm here. Now just remember to check the order for the type of feeding formula, volume and frequency, and then gather the supplies, okay?
Okay, great.
Thanks.
Hi, Mr. Torres. This is Miss Swenson, my instructor.
Hello.
She's going to be helping me give you your nutrition supplement. Since the pump's not working, we're going to have to deliver it by gravity. That'll take about a half an hour. Once it's done, I'll disconnect the tubing, okay?
I'm at your service.
Okay, great. I'm going to just check your ID band first. Can you tell me your full name?
Carlos Torres.
Okay. Now I'm going to position the head of the bed at least 30 degrees, or as near normal eating position as possible. Are you good there? Okay. Lift you up a little bit.
Now hang the feeding bag set on the IV pole and adjust it to be about 12 inches above the patient's stomach.
Okay.
Now clamp the tubing on the setup.
Now I clean the top of the can with an alcohol wipe, right? Okay, now I'm going to pour the formula into the feeding bag.
Okay, be sure to open the roller clamp and run the formula through the tubing to purge the air.
Okay, all the air is out. I'll close the clamp again. Now I'm going to check the residual, or the amount of feeding that's left in the stomach from the last feeding. I'm going to have to pull your gown up just a little bit, okay, Mr. Torres? I'll be sure to use a waterproof pad.
Great. Now aspirate gastric contents with a syringe and measure. Then you want to return the contents immediately through the tube.
I'll put it back in. Now I'm going to flush with 30 cc's of water. Okay. Since the residual did not exceed the facility policy or the doctor's orders, I can continue with the feeding.
Very good. Clamp the PEG tube. Now attach the feeding setup to the feeding tube. Open the roller clamp.
Okay.
And adjust the drip rate according to the infusion time ordered, or allow it to infuse over at least 30 minutes.
I've calculated a drip rate of 80 drops per minute.
Great.
Okay, Mr. Torres. We'll be back when your feeding is complete.
Sounds good to me.
Hi again, Mr. Torres. How you feeling?
No dramatic changes.
Okay. What I'm going to do now is I'm going to flush the feeding bag with 30 milliliters of water. That way we can flush out the bag itself and your PEG tube at the same time. I'll draw it up in here. That's 30.
Then clamp the tubing as soon as the water is instilled.
Okay, now I'll disconnect the tubing from the PEG.
Apply the cap to the end of the tube, Jeannie.
Okay, Mr. Torres, I'm going to have you sit in an upright position for 30 to 60 minutes. Is that okay?
That I can do.
Okay. If you have any questions or concerns, don't hesitate to ring your bell.
Thank you, Mr. Torres. We'll go over that.
Okay.
Okay, Tamika, have you had a chance to irrigate your patient's NG tube?
Well, she's scheduled for irrigation every 4 hours with normal saline, and she's coming up on that about now.
Why don't we go over how to do that?
Okay.
Do you have your supplies?
Yeah, I think I'm all set.
All right, let's go.
Okay. Hi, Mrs.
Hi.
Bailey. I'm going to check the tube that goes into your stomach. To keep it working properly, I'll need to flush it with a solution. And when I do this, it might feel cold going down your throat, but it won't hurt.
Oh, okay. Take your time.
Okay. All right. Can you tell me your name, please?
Kate Bailey.
Great. Now, do you mind if I put down this pad just to keep you from getting wet in case we need it?
Oh, no.
Okay,
not at all.
thank you. All right, now I'm just going to raise you a little bit. Okay. All right.
So to start, we'll pour the irrigating solution into the container.
Okay.
Be sure to lip it.
Okay.
And we'll check the placement of the tube by aspirating gastric contents.
Okay.
Now disconnect the NG tube from the suction apparatus and lay the tubing on the disposable pad. Place the tip of the syringe in the nasogastric tube. Now we're using a Salem sump or double lumen tube, so make sure the syringe tip is placed in the drainage port.
Okay, not the air vent.
Mm-hmm.
Okay.
Good. Now draw up 30 milliliters of the solution, or the specific amount ordered, into the syringe.
Okay.
Great. Now hold the syringe upright,
Okay.
unclamp, and gently insert the irrigation solution into the tube. Now some policies may require that the solution flow in by gravity, so be sure not to force the solution into the tube.
Okay. Now I clamp again and connect the NG tube back to the suction unit and unclamp to withdraw the fluid.
or you can withdraw or aspirate an equal amount of fluid back into the syringe.
Okay. What if I don't get a return?
Then you would inject 20 milliliters of air into the tube and aspirate again.
Okay. And I should observe the movement of the solution or drainage.
Note the amount of irrigation solution used and the characteristics of the return solution.
Got that. Now, once I've washed up, I'll make sure to document the irrigation procedure, a description of the drainage, and the patient's response according to the facility policies.
You've got it. Mrs. Bailey, thank you very much.
Oh, I didn't need to do much. No need for thank yous. Bye.
Okay, Mrs. Bailey, can I do anything else for you?
I could use some more cold water for my mouth swabs.
Okay. Coming right up, and some more swabs, too.
Okay, thanks.
Okay.
Hey, Robert. One of the nurses has asked that we assist with removal of an NG tube. Now, the patient is post-op from abdominal surgery. What criteria do you think were used to determine the tube could be removed?
Well, I would think that the patient's appetite's returned and bowel sounds are present.
Right. And he also would be passing flatus, another sign that intestinal function has returned.
Right.
So let's check the order for the NG removal, gather our supplies, then we'll go see the patient.
All right, we'll do that. Hi, Mr. Needleman. How's it going?
Okay.
That's my instructor, Miss Swenson.
Hello.
She'll be observing for a little bit. Now, the doctor has said that your stomach tube can come out, and the nurse asked us to remove it. Now, I know that your doctor has explained it to you. Do you have any question?
That's good that it's coming out, because that's one step closer to going home.
That's great. Now, I'm going to go over each step with you as I go along, okay?
Okay.
All right, I know you're going to feel some discomfort for the first few seconds. Then your nose and throat will feel much better once the tube is out. Get this under you here. All right. May I see your ID band? Can you tell me your name?
Stanley Needleman.
Okay, thank you. Just going to raise your bed up a little bit here. Okay. And I'm going to lower your railing. There we go. All right.
Okay, we'll discontinue the suction and detach the safety pin holding the tube from the patient's gown. Now we'll take off the adhesive tape from the patient's nose.
Yeah, we'll find out if I have any blackheads, you know, like those strips.
I don't think that adhesive tape can do that. There we go.
Separate the NG tube from the suction tubing. Aspirate the gastric contents with the syringe to check replacement of the tube. And flush the NG tube with normal saline.
I could also use 30 to 50 cc's of air to clear the NG tube.
Yes, you could. Just be sure to check the facility's policy.
Okay, Mr. Needleman. I'm going to have you take a deep breath and hold it while I pull out the tube, okay?
Now clamp the NG tube with your fingers by doubling it on itself to pinch it off.
Okay. All right, ready? 1, 2, 3, big breath. There we go. Good job. Now I'll just put the tube in the appropriate disposable bag.
Ah, freedom.
Good job, Robert. Now be sure to measure the NG drainage and dispose of the container and equipment according to policy. Okay, Robert. Now you should continue to monitor the patient for gastric distension, nausea, or vomiting.
I'll document the removal of the tube, the patient's response to the procedure, and the amount and character of the drainage according to facility policy.
Also offer him mouth care, okay?
Okay, thanks.
All right. Thank you so much, Mr. Needleman.
My pleasure.
Yeah, I do play bass in a band.
Okay, so guys, today Jeannie had a patient with a PEG tube, which is a percutaneous endoscopic gastrostomy tube. Jeannie, why don't you tell everyone what that's used for?
Long-term nutritional support.
Right. And the procedure for administering feedings is similar regardless of the tube used. Okay? Now, most of the feedings you administered today were intermittent. They can also be administered continuously over 24 hours. And a feeding pump is always used for these. Let's see, Robert. You had a patient receiving a continuous feeding. Can you tell us a little bit about that?
Well, with a continuous feeding, it's important to check for residual, the amount of feeding remaining in the stomach, and confirm placement of the tube every 4 to 6 hours, right?
Exactly right. Okay, now I'd like to take just a minute to try and answer any questions you might have about the things we've looked at today.
Well, I know we've gone over it, but I think I would get nervous when inserting a tube and the patient coughs and gags. Is there a simple checklist I can have in my head when that happens?
There definitely is, Robert. Let's walk through a situation. Let's assume Jeannie has a patient. You're inserting a nasogastric tube into your patient. You've inserted it into her nose and have just asked her to start swallowing the water to advance the tube. As you advance the tube, the patient begins to cough and choke. We start by asking the patient a question.
Okay, can you tell me your name? Okay, I'll
Why
write
is
that
that?
out.
Well, we want to assess the patient's ability to make sounds with an answer. If the patient coughs, gasps, is unable to speak, or becomes cyanotic, you'd remove the tube.
Okay, good. Now, what would these signs indicate, Jeannie?
It would indicate that the tube is in the patient's airway and not the esophagus.
And once you've removed the tube, assess the patient's respiratory status and check her vital signs.
Right, and allow her ample time to recover.
Exactly. And if the symptoms continue after the tube is removed, notify the primary care provider. Now, what happens after the patient recovers?
Well, I would try to insert the tube in the other nostril, unless it was contraindicated.
What position should the patient be in?
The patient should be in a high Fowler's position, unless it's not possible.
And her head position?
Well, once the tube reached the pharynx, I would instruct the patient to put her chin to her chest.
Okay, very good. Now remember to advance the tube while the patient is swallowing and to pause when the patient breathes. If you have any more problems, stop, remove the tube, and contact the physician, okay?
Okay.
Sounds good.
All right, have any of you had to deal with something unexpected with NG tubes?
I did not too long ago. My patient had a nasogastric tube connected to suction for stomach decompression. And as I was irrigating the tube, I met a lot of resistance after attaching the syringe of irrigant to the NG tube. I wasn't able to flush the tube.
So what did you do?
Well, first I repositioned the patient and tried again. I knew that sometimes the patient's position pushes the end of the tube against the stomach wall.
Mm-hmm. Very good. And then what?
After that, I still met resistance. So I used 20 cc's of air rather than irrigation solution, and that worked. The air helped reposition the end of the tube.
What about the patient?
I assessed the patient for other symptoms such as nausea, vomiting, feeling of gastric fullness or abdominal distension, but everything was fine.
Very good. Now remember to notify the primary care provider if repeated attempts to irrigate the tube fail. Okay. Any questions? Then well done today.
Okay, thank you.
Thanks a lot. See you guys tomorrow.
All right,
See you later.
thank you. So does it work? The music, does it work for you?
Yeah, it does.
Really? Could I borrow it? Because I want to
Sure.
study tonight. I want to try it out.
Well, I've got plenty at home, so it's all right.
Okay. Thank you.
Here you go.
All right, I'll give it back.
Too slow.
I'll give it back to you tomorrow.
All right.